Good evening, everyone, and welcome. My name is Dr. Tim Lubenow. I'm an anesthesiologist and interventional pain specialist in Chicago. Um, Welcome to this webinar of the ASPN Young Innovators Committee. I and my co-moderators serve as co-chairs on the Young Innovators Committee of ASPN, and it is this mechanism that we use to train pain fellows about certain aspects of interventional pain medicine. So you should think of this particular series of presentations as fellows teaching other fellows. Joining me tonight are my co-moderators, Dr. Yusur Ibrahim and Dr. Danielle Pack, who will introduce themselves and then introduce our speakers. So Yusur and Danielle, please introduce yourself.
Thank you for the introduction, Dr. Lubenow. Hello, everyone. My name is Yusur Ibrahim. I'm an interventional pain physician practicing out of Wisconsin. I want to thank you all for joining us this evening. We will be walking you through our webinar discussing surgical techniques. I'm sure you will all find this helpful in your day-to-day clinical practice. I'm happy to turn this over to my moderator, Dr. Pak, who will be introducing our panelists.
Thanks, Dr. Ibrahim. Again, my name is Dan Pak. I'm a faculty at UT Health in Houston. As the two people before me have alluded to, as the field of pain medicine and interventional spine has really adopted much more minimally invasive surgeries, it's really crucial, I think, for early career physicians to not only know, for example, where to place a needle or a lead, but also understand the surgical principles that makes those interventions safe, reproducible, and effective. So I think today's discussion is really going to focus on a lot of these practical techniques that can elevate procedural success, while also, of course, minimizing complications. So we have three excellent speakers with us today. We have Dr. Benjamin Suferi from the Cleveland Clinic. We have Dr. Adam DeLaura from Rush University, and then also Dr. Sarang Singh from the Brigham. We'll take questions at the end, so please use the chat box, and we will address them after everyone has done speaking. So with that, I'll let Dr. Suferi start our webinar off.
Thank you very much, Dr. Pak. Hi, everyone. My name is Benjamin Suferi, and I am a pain management fellow at the Cleveland Clinic. Next slide, please. I will begin by focusing on the phases of wound healing because understanding the biology clarifies why surgical technique matters. If you understand what the tissue is doing at each stage, what cells are present, how the extracellular matrix evolves, and how mechanical strength develops, then principles such as gentle tissue handling, meticulous hemostasis, preservation of blood supply, and appropriate closure become biologically intuitive. Wound healing should be understood as a coordinated biological process rather than a single event. It consists of a series of overlapping phases that are tightly regulated at the cellular and molecular level. Successful healing requires appropriate progression through each phase, and disruption at any point, whether due to surgical technique, ischemia, infection, or excessive tissue trauma, can compromise the final outcome. This slide provides a global overview of the wound healing timeline. The x-axis represents time following injury on a logarithmic scale, while the y-axis reflects the magnitude of the biological response. Immediately after injury, the body initiates hemostasis and inflammation, which are essential for bleeding control and immune defense. As the wound stabilizes, the process shifts into the proliferative phase, characterized by fibroblast activity, angiogenesis, epidermal regeneration, and extracellular matrix deposition. The final phase is remodeling or maturation, during which extracellular matrix is reorganized, cellularity and vascularity decrease, and tensile strength progressively increases. The key concept illustrated here is that wound healing is dynamic and highly dependent on the orderly progression through these phases, which is directly influenced by surgical technique. In the next several slides, I'll review each of these phases in more detail, focusing on the underlying biology and highlighting how our intraoperative decisions can either support normal progression or contribute to delayed or complicated healing. The first phase begins immediately after injury and is focused on rapidly controlling bleeding and stabilizing the wound environment. Vasoactive biogenic amines stimulate initial local vasoconstriction, which reduces blood loss at the injury site. Platelets then fill injured area by binding exposed von Willebrand factor, which attracts additional circulating platelets. These platelets form a platelet plug, providing immediate hemostatic control. In parallel, activated platelets and an injured subendothelium signal both the extrinsic and intrinsic coagulation cascades, which sets the stage for fibrin formation and stabilization of the clot. Next slide. The intrinsic and extrinsic coagulation pathways converge on the common pathway, resulting in fibrin activation and cross-linking, producing a stable fibrin mesh. This fibrin mesh stabilizes the clot and serves as a scaffold for cellular migration during subsequent phases of healing. Clinically, this helps explain why inadequate hemostasis can create hematoma and dead space that disrupts later healing, while overly aggressive thermal injury can impair perfusion and compromise the wound environment. Next slide. Once initial hemostasis is achieved, the wound enters phase 2, the inflammatory phase. After approximately 5 to 10 minutes, the surrounding vessels begin to dilate, increasing local blood flow and vascular permeability. The aggregated platelets then help recruit the early inflammatory infiltrate, specifically attracting neutrophils and macrophages. In the first 24 hours, neutrophils are predominant, functioning as the primary early responders. Then after approximately 2 to 5 days, many of those neutrophils die, and this transition promotes the recruitment of macrophages. Next slide. Macrophages are present throughout most of the inflammatory phase. After clearing debris and bacteria, macrophages secrete cytokines that stimulate angiogenesis and fibroplasia. A prolonged inflammatory phase can lead to chronic wounds, impaired healing, and increased scar formation. Inflammation is necessary for cellular debridement of the wound, as effective clearing of damaged tissue and contaminants helps prepare the wound for organized repair. Next slide, please. The proliferative phase is the period of active tissue rebuilding and barrier restoration. The slide lists 3 key components. First is epidermal regeneration, where stem cells differentiate into keratinocytes and migrate over the wound surface. Second is capillary budding. This is the beginning of angiogenesis. It restores oxygen delivery and supports metabolically active repair tissue. Third, an extracellular matrix forms to fill the defects of the wound. This newly formed barrier helps prevent further fluid loss and bacterial invasion. Fibroblasts near the wound begin producing type 3 collagen, and some fibroblasts differentiate into myofibroblasts, which generate contractile forces and begin approximating the wound edges. Next slide. The final phase is remodeling or maturation, which is where early repair tissue becomes mechanically stronger and more organized. This phase is important for organized deposition of collagen. Initially, in the miniature scar, there is a higher percentage of type 3 collagen compared to uninjured skin. As the wound matures, the proportion of type 3 collagen decreases, and there's a corresponding increase in type 1 collagen, which contributes to improved strength and durability. Over the course of a year, granulation tissue is degraded and excess blood vessels retract, reflecting the transition from highly vascular repair tissue to a more stable, mature scar. Next slide. This graph reinforces the timing and relative magnitude of matrix components during healing. It demonstrates changing relative amounts of matrix synthesis over days post-wounding, including the early prominence of fibronectin and type 3 collagen, followed by later increases in mature collagen patterns. Importantly, it also shows that wound breaking strength increases over time, which aligns with the biologic shift toward collagen maturation and remodeling. Clinically, this helps explain why wounds can look healed superficially while still gaining mechanical strength over an extended period. Next slide. If a wound has failed to heal within 4 weeks, it's considered chronic. Factors that influence wound healing include age, nutrition, poor vascular perfusion, medications, radiation, chemotherapy, and infection. The key procedural takeaway is the balancing act. It is important to achieve hemostasis while still allowing the wound to maintain good blood supply for appropriate healing. This is where surgical technique directly affects biology. Next slide. This slide introduces the basic tenets of Halsted, often referred to as Halsted's principles, which form the foundation of modern surgical technique and tissue handling. These principles were introduced in the late 19th century by Dr. William Stewart Halsted, who is widely regarded as the founder of American surgery. Beyond his historical significance, he was a pioneer in many of the techniques we now take for granted, including aseptic technique and principles of surgical closure. What is remarkable is how relevant these concepts remain today, even in minimally invasive and percutaneous procedures. The core principles include gentle tissue handling, meticulous hemostasis, preservation of blood supply, minimizing tension on tissue closures, accurate tissue apposition, obliteration of dead space, and crush-free dissection. He also emphasized the strict principles of sterility, including the use of scrub suits and sterile gloves. When viewed through the lens of wound healing, these principles directly support normal biological progression. Gentle tissue handling limits unnecessary inflammation, meticulous hemostasis, prevents hematoma and dead space, preservation of blood supply supports angiogenesis, and the proper tissue approximation facilitates organized collagen deposition. In other words, Halstead's principles are not just technical preferences, they are biologically grounded strategies that promote predictable healing. His principles have been adapted to modern pain and neuromodulation procedures through the recommendations of the Neuromodulation Appropriateness Consensus Committee, specifically for spinal cord stimulation implantation. The NACC emphasizes that successful SCS implantation requires both cognitive and motor surgical skills. These include strict aseptic technique, appropriate identification and handling of surgical instruments, and proficiency in suturing, knot tying, or alternative ligation techniques necessary to complete the implant safely. Equally important is an understanding of sharp versus gentle blunt dissection, accurate perception of tissue planes, and gentle tissue manipulation that minimizes tension. These skills directly influence tissue viability and wound healing. Maintaining hemostasis and appropriate use of electrocautery are emphasized to balance bleeding control with preservation of blood supply. These recommendations also highlight the elimination of wound dead space and precise closure and approximation of tissues. Dead space is the enemy of predictable wound healing. Not only can it delay healing, but it also creates a medium for bacterial proliferation. In the context of neuromodulation, these steps are particularly important for preventing infection, seroma formation, and device migration. A dry field is important, but overly aggressive cautery can devitalize tissue. Tissue that appears hemostatic but ischemic may ultimately compromise healing. Taken together, this slide reinforces that spinal cord stimulation is not simply a device-based procedure, it is a surgical operation. When we integrate wound healing biology with Halstead's surgical tenets and modern neuromodulation recommendations, the message becomes clear. Technical precision is not optional. It directly influences complication rates, device longevity, and patient outcomes. With that framework established, we can now transition from principle to practice, reviewing the instruments and materials, closure techniques, and procedural details that operationalize these concepts in daily interventional pain practice. For that, I'll be introducing Dr. Adam DeLaura.
Thanks, Dr. Safari. Great job. So my name is Adam DeLaura. I'm a Rush Pain Medicine Fellow, and we're going to talk about commonly used surgical instruments. And the reason we're talking about commonly used surgical instruments is because you want to have great communication with your surgical technician and inspire confidence in your knowledge of the devices and how they're used and what their names are. So we're going to start with basic materials that you're going to start out with to maintain a sterile field. You're going to have non-traumatic hair clippers that won't cause any cuts in the skin. You're going to have some sterile blue towels, which you can see on that stand on the right. There's going to be some sterile drapes as well. There's also on the right side of the picture shown, there's some gauze, some Raytech gauze. Raytech gauze are cotton-based and have a radio-opaque blue ribbon throughout them so that you don't leave any materials within the patient. And if you do, you can go ahead and take an x-ray and you can find them. There's also ChloraPrep, iodine, and alcohol-based scrubs that you can use. There is Iovan as well, which is an antimicrobial incise drape that we're going to talk a little bit more about on the next slide. And there's handle covers as well, so you don't break sterility with the light handles. And then there's also a sterile C-arm cover that we're going to see in the next slide as well. So we can go ahead and advance to the next slide. So this is Iovan placed on top of the patient, and it's an adherent incise draping material that adheres to the patient so that the field doesn't move. And in addition, it continuously releases iodine as an antimicrobial mechanism. There's also a sterile drape over the C-arm as well to help maintain your sterile field. And then you can see those blue towels and the drapes on top of that to maintain your sterile field. Next slide. Some of the basic surgical instruments we're going to run through very quickly, and then we'll look at them more closely. later in the presentation. So you'll have a skin marker, which often has a permanent and non-permanent side. There's going to be needles as well, including introducer needles to go ahead and gain access to the epidural space. There's going to be some syringes, including loss of resistance syringes, local anesthetic and scalpels to create your incision, some electrical surgical unit, which can be used for gaining hemostasis. There's also needle holders as well, and pickups and forceps to expose the tissues. You're also going to have tissue scissors and suture scissors, which we'll look at a little bit later. There's hemostats for grabbing tissue and different things that you're probably going to crush or grab drapes. There's also irrigation as well to dilute any infection, any bacteria, and clean any wounds. There's also some suction devices, which we'll talk again a little bit later. Anchors to keep the spinal cord stimulator leads in place from migrating, and some tunneling devices, and then some sutures and staples as well. Next slide. So this is your basic Mayo stand setup. So generally, your surgical technician will go ahead and set up a back table and then a Mayo stand, which is used for things that are going to be used in the next steps of the procedure. Going from left to right, you can see a needle driver with some sutures in it. And there's also a sharps pad as well beneath that red sharps pad. There's a hemorrhoidal clamp there, and then some anchors as well, and a tunneling device and some scissors, and an S retractor so that you can see a little bit better. There's some irrigation with a bulb syringe to dilute any infectants, and then you can see some spinal cord stimulator leads and some DeBakey pickups. There's some needles up top and a loss of resistance syringe to gain access to the epidural space. And then there's a self-retraining Wheatlander retractor, which we'll talk about a little bit later. Next slide. So different types of scalpels that you'll use. The scalpels are usually used for initial incisions and cutting any type of tissue. So you'll make your initial incision when you're creating any pockets or opening up a wound, and then subsequently you can use electrocautery for hemostasis. But there's different types of blades that can be used for different types of cuts. So a 10 blade is often used for primary large skin incisions. 15 blade is a smaller form of that for making finer incisions. And then the 11 blade is more used for puncture, precise, angulated type incisions. So if you are creating a tract for your anchors, you might use more of a puncture type incision. So you'll ask for a 10 blade, 11 blade, or 15 blade from your surgical technician, and they'll have that loaded up for you. The fingertip grip is the most common grip that can be used, but you'll also see more pencil type grips as well. The benefits of the fingertip grip is it allows for accuracy and blade stability. You can use your index finger to press and exert a little bit more pressure or less. And you can use your non-dominant hand to stress the skin and advance the blade until the incision is complete. Next slide. This is an electrosurgical unit. So this is developed in the 1920s by William Bovey. It's most commonly called a Bovey. So you'll ask your surgical technician, can you hand me a Bovey? And that'll be the electrical surgical device that will dissect tissues and both coagulate and gain hemostasis. So there's two different types of Boveys. One is a monopolar Bovey, which is a pencil-like device where you'll have a grounding pad and the pencil, and the high frequency electrical current will go from the Bovey, and you can go ahead and gain hemostasis in tissues, and then it'll go to the grounding pad, which will be placed on an area of the patient without any metal in it. There's also bipolar forceps, which go between the two tips. The electrical current goes in between the two tips of the device. So it can be used for vessel sealing and different things like that. The monopolar Bovey can also be used in combination with metal pickups. So the electrical current will propagate through any metal devices as well, which can be of benefit. So if you're trying to gain hemostasis on a vessel, you might grab it with a DeBakey and then apply the monopolar to it. The downside of this is it can also damage tissue inadvertently, so it's something to watch out for. Next slide. So in electrosurgery, there's an example of a bovie on the right side. So to dissect or cut tissue, you press the yellow button, and that's used to separate tissues. And you can also coagulate tissue. So if you're trying to gain hemostasis, you'll press the blue button and apply it to the tissue after you made your incision or you have some kind of bleeding deep within a wound. The electrical surgical unit settings can be changed depending on the type of tissue. So you can set these or have your circulating nurse set these on the actual electrical surgical unit itself, depending on what type of tissue you're trying to coagulate or dissect. Next slide. There are different types of needle holders and drivers depending on what type of space that you're working in. So there's several different types of needle holders depending on the depth of the tissue and what you're working on. There's a Webster type shown on the left, which can be used for extra delicate inner jaws, and you use that for a 3/0 or finer sutures. If you're working in a deeper pocket, you want something a little bit longer or something else. There's also different types of needle drivers, like the Halsey type or the Mayo-Hedger type. So the Mayo-Hedger type will have a longer handle, whereas the Halsey type will be somewhere in between with different types of teeth. And there's also cutting variants as well, where you can have like within the jaws, you can cut your own sutures. So different types depending on what you're doing. There are also different grips that the needle holders can be used for. So depending on what you're doing, you might choose a wide base tripod grip. The downside of this grip is it doesn't allow for liberal wrist movement. So you might, if you're trying to get a good bite of the tissue or really twist your wrist and make sure the needle's following a tract, you might use a palmar grip or some modified thinner eminence grip to really get a good bite of tissue. Next slide. So how do you use or load a needle? So there's two sides to the needle. There's a needle tip, and then there's the swedge, which is the side that's connected to the thread of the needle. So you want to be about 1/3 away from the swedge and then 2/3 away from the needle tip. And what that will allow you to do is get a good bite and have good suture control and grab it on the other side sufficiently once it's through the tissue. Next slide. There are different types of tissue forceps and pickups. Your tissue forceps are incredibly important for manipulating tissues and getting good visualization as you're doing things like suturing, gaining hemostasis, or creating different pockets and going through tissue planes. So they're also used to graft suture and needles on the other side when you're throwing a suture. So adequate retraction of tissues to optimize exposure is incredibly important, and you want to make sure you can see what you're working with. So allowing the tissues to retract adequately is incredibly important. Considerations, there's different sizes and lengths and designs, and we'll talk about a few of the different types of tissue forcep pickups. In addition, different types of teeth are used on the forceps to either crush the tissue or not crush the tissue, or provide little punctures depending on what type of tissue you're working with. You don't want to be devitalizing the skin and crushing the tissue with some toothless forceps. So depending on where you're working, you're going to pick a different type of pickup. Next slide. So starting on the left side, we have Adson pickups, which are toothed at the tip and used to handle skin closures and dense tissue. So again, this doesn't really, because it's toothed, it doesn't crush the tissue as much. So if you're working on skin, you don't want to crush the skin. DeBakey pickups would be the next type that you can see in the middle. They're used for atraumatic tissue grasping, and we tend to use them for lower tissues within the pocket. When you're closing fascial layers, you might use these as opposed to an Adson pickup on the skin. They're used for manipulation of vessels and fragile tissues. And then on the right, we have some non-tooth pickups that can be used as well. Next slide. Different ways to hold the pickups. So they can be held in the non-dominant hand, because usually if you're suturing, you want the actual needle driver in your dominant hand. We generally like to use a pencil type grip for better dexterity and management of whatever you're picking up. So having this overhand grip that you can see on the right side will hamper maneuverability and make it a little bit more difficult. You also don't want to crush tissues, so having that fine grip that you can see on the left side really allows for accurate tissue manipulation in a delicate manner, so you're not crushing skin and things like that and crushing the tissue that you're working with. Next slide. So these are different types of scissors that you might come across. So they're used for cutting tissue or for dissection. So there are sharp tips, there's blunt tips, depending on what you're using them for. There are cutting edge, serrated edge, and different types, and straightened curves. So depending on what you're using them for, you might pick up a different type of scissor. So in the middle, you'll see some Mayo scissors that can be used for cutting sutures most commonly. And then you'll also see some Mayo scissors that are curved as well. So there's different types of Mayo scissors. So you'll see the straight and the curved. There's also Metzenbaum scissors, which are for fine tissue dissection, which might be a little bit sharper. So if you're placing an intrathecal pump and you want to cut a catheter, oftentimes the Metzenbaum scissors will be a little bit sharper. So it really depends where you're working and what you want to cut. So suture scissors versus tissue scissors and understanding the difference is very important. Next slide. There are different types of clamps. So there's a hemostat used to grab tissue in vessels. I also like to use hemostats when I'm dissecting a scar out of a patient when we're doing some types of revision, and I know that the tissue is not going to be used and I want a really great grasp on it. There's also Kelly clamps, which are larger than a hemostat. There's also smaller clamps like mosquitoes that can be used to grab sutures and keep them out of the field when you're working and you have a suture thrown. There's a Coker, which is used as a tooth clamp that can grab devices. So if you're doing a revision and you want to go ahead and take out a device, you can go ahead and grab it with a Coker. The Alice clamp is often used for towels, and it has slightly rounded jaws. There's also some towel clamps as well, which can be used to secure drapes. Oftentimes staples are used for this purpose as well. Next slide. These are different types of retractors used to hold the incision open and help to visualize and maintain a sterile surgical field. Different types are, you can have handheld, which are some of the top two that you see on the right, and then a self-retaining via ratcheting mechanism, which is similar to the Wheatlander, and we'll talk about that in a second. So the Army Navy is used to gain exposure to skin layers. It's usually pretty small and shallow, and you can apply handheld traction with these. There's also a Sen molar, which is also called an S retractor or a Sen retractor more commonly. It's double-ended and it has an L-shaped handle with 3 prongs to go ahead and grab and retract skin. And then there's also a more blunt side on the other side. There's also a Wheatlander retractor, more commonly called a Wheatie. And it's a self-retraining retractor. So as you open it up, it has a ratcheting clicking mechanism that'll keep it open. And you can use this to keep a wound open. You can also grab the Wheatlander and lift it to get it away from other tissues. So if you're opening up a pocket and you want to gain some exposure, you can actually lift up the tissue utilizing the Wheatlander and dissect with your other hand. So it has blades pointing downwards and prongs, and then you can just set up the self-retraining retractor and it'll open up and allow you to see the tissues better. And there's different sizes of these as well. Next slide. Suction. So there are different types of suctioning systems, and then in addition to that, there's also different suction tips. So the purpose of suction is to remove debris and fluid from the surgical field. It can also help clear smoke. So if you're using electrocautery and there's a lot of smoke coming up, you don't want to breathe that in. It's carcinogenic. So you can use the suction system to suck out that smoke and also improve visualization. This is a Fraser suction commonly used in ENT, shown there. It only comes in a metal type, and it is often used in ENT type procedures, whereas we commonly use Yankauer suctions in our procedures. There's plastic and metal types of these, and it can be used for surface suction and superficial wounds as well. So different types of suctioning tips are often available. Next slide. All right, I'm going to go ahead and hand it off to Dr. Sarag Singh, who's going to be talking about different suture types and surgical techniques for 3-layer closures. So hand it off to you, Dr. Singh.
Thank you so much, Dr. Delora. That was fantastic. Good evening, everyone. My name is Sarag Singh, and I'm a pain management fellow here at Brigham and Women's Hospital in Boston. We're now going to review some different closure materials used in surgical practice. Next slide, please. So this is a great title slide that's really going to encompass what we're going to go over the next few slides, including needles, sutures, and then talk a little bit about skin glue and staples. Next slide, please. So in terms of needle types, it's great to break it down first into their shapes and sizes and how they can be used. So we'll start by talking about a CT needle versus an SH needle. A CT needle is essentially a circle tapered needle. These are going to be much more curved, as you can see on this slide, and they're really designed for those deeper layers of closure. This is because those fascial planes are going to have much more confined spaces when you enter through them, and you're going to need that curve to help you get into those spaces. An SH needle, by contrast, is going to be a small half circle shape. This is far less curved, and it's going to be more appropriate for those superficial layers. This is suitable for the subcutaneous tissue and the skin. Overall, the difference between these needles really showcases how curvature is going to affect the maneuverability and the depth control that you're going to have with each throw. Next slide, please. Needles can be further differentiated into being either tapered or cutting needles. A tapered needle is going to have a blunt tip. This allows it to spread the tissue rather than cutting it, which is very important for those deeper, delicate tissues such as fascia and muscle. Cutting needles, by contrast, are going to have a sharp cutting edge, which makes them useful for skin and dense tissue that you want to go through very quickly without inducing too much trauma. It allows you to have much more control as you pass through these tougher tissues. There's also a third type of needle that's described on this slide that we call a reverse cutting needle. And this is really the needle of choice for that superficial skin closure. That's because it has the cutting edge on the convex side. And this allows us to get through that superficial dermal layer and reduce the amount of tissue tearing, needle bending, and suture pull through that you do as you close towards you. Next slide, please. So as you can imagine, sutures come in many different shapes, and sizes. In general, the moniker that we use is a numbered system, where more zeros equates to a smaller diameter overall. So for example, a 4-0 suture is going to be smaller than a 3-0. The clinical importance for this is that if you have too fine of a suture, it increases the risk for wound dehiscence and a lack of integrity overall. By contrast, if you have a suture that is much more coarse and thicker in diameter, it can be useful for keeping the tissue adhered. However, it's going to cause more irritation locally at the site. And this is important to consider as it then increases your infection risk there. So you need to have a comprehensive understanding of these sutures available so you can correctly match which suture you want to use and its strength for the level of tissue tension that you want to induce as you close. Next slide, please. Furthermore, on this slide, you can see how sutures can also be further differentiated into absorbable and non-absorbable types. And both of these types can exist as either braided or monofilament sutures. As we break it down, braided sutures are going to have a higher tensile strength overall. This is because the braided structure has interdigitations that allows for more fibroblast proliferation, which is going to help form that firm, watertight scar formation that you want over things such as anchors and hardware. By contrast, monofilament sutures are much more homogeneous in their composition. This allows them to have a lower tissue drag overall and less fibroblastic proliferation, therefore having less inflammation at those sites. Monofilament sutures in general can be preferred when cosmesis is a little bit more important. Of note, I want to highlight the bottom right corner of this slide that denotes that the NAC guidelines don't actually differentiate any clear evidence that staples, sutures, or skin glue are superior to the others when they are compared for skin closure. Next slide, please. So now we're going to just briefly transition into surgical technique for the remainder of this for this lecture, and then we're going to finish up talking about sort of wound management and infection prevention. In reference to surgical technique, it's important to remind ourselves of some of the things earlier said in this lecture about the surgical tenets of Halsted. I want to highlight two main tenets here that I'll continue to reference over the next few slides, which is preserving blood supply and minimizing the amount of tissue tension that you have. Blood supply is important to preserve, of course, because as local ischemia forms, it can lead to necrosis and increase your risk for infection. Conversely, if you induce too much tissue tension at certain sites, that will increase your risk for dehiscence and infection as well. And so these are two commonly overlooked contributors to wound complications that can be really troublesome overall. Next slide, please. So here we have another tray. This is kind of a typical tray setup that you would have for a spinal cord stimulator implant. Dr. Delora already did a great job reviewing about your typical Mayo stand, so I'll just kind of run through this quickly for your review, running in order from 1 through 16 shown on the screen here. You have rubber shots for hemostats, a glass loss of syringe, a glass loss of resistance syringe. You have a ethibond suture, which is typically appropriate for leads and IPG anchoring. You then have vicryl suture next to it, which is more appropriate for that fascial and subdermal closure. A Yankauer suction setup, Wheatlander retractor, bipolar cautery, and monopolar cautery is also used quite often as well. A radiographic marker, Mayo scissors, which are typically used for cutting sutures, scalpel handles, Metzenbaum scissors, which are typically used for dissection, Adson Brown forceps, which we utilize with the superficial closure when grabbing skin, DeBakey Gerald forceps, which we use in deeper layers when we're grabbing those deeper tissues, Sen retractors, Army Navy retractors, and then some Parker retractors at the end. Next slide, please. So this cartoon really brings us to the idea of the 3-layer closure, and it does a great job of visualizing it. So the typical pocket location that you're going to choose is obviously going to be a conversation between provider and patient, but it's generally for IPG implants, for stimulators and similar neuromodulation, we tend to use the posterior flank of the patient. For this reason, patients are typically placed in a prone position for these procedures. In terms of creating the pocket, you'll start with a sharp dissection through skin and Camper's fascia just beneath it. The next step is to advance through Camper's fascia, being careful to maintain hemostasis, and to identify the scarpus fascia, which is going to be shown in this green layer on this cartoon. This is going to allow you to enter that avascular plane, which is going to be just above your muscle, which is deep to scarpus fascia. During this dissection, you can utilize blunt dissection very well to actually enlarge the pocket size while minimizing the amount of tissue trauma that you're going to have. For the purpose of generator implants, in general, it's recommended to place the IPG at a depth of about 4 centimeters or less if it's a non-rechargeable battery, and about 2 centimeters or less if it's rechargeable. The latter being important to acknowledge because it ensures great accessibility for charging and connectivity. The purpose overall for this 3-layer closure technique that you need to consider at all times is that its goal is to minimize dead space, reduce tension across your tissue layers, lower infection risk, and therefore improve healing. Next slide, please. We can break these down a little bit more over the next few slides, talking about the layers for closure from most deep to superficial. So starting at the deep fascial layer, we typically recommend utilizing a non-dissolvable suture here. You would typically perform interrupted buried sutures here with spacing at approximately less than 5 millimeters apart. The technique that Dr. Delora had described earlier with his needle driver is going to be utilized here. We're going to use the needle driver in the dominant hand and initially enter the fascial layer from deep to a superficial fashion on the contralateral side. You'll then bring the needle driver back towards the ipsilateral side where it's held and re-enter from superficial to deep at the same layer. An instrument tie or a hand tie is then going to be performed. And by performing it in this fashion, this ensures that the knot that you make is secure and it's buried beneath the layer that you are trying to close, which aids in both tissue approximation and cosmetics overall. Next slide, please. Next, we can talk about the subdermal layer, which is a really important layer that helps reapproximate the tissue and minimize dead space. And this is your best chance to further reapproximate the tissue before you get to that final superficial skin layer, which is so important for cosmetics and minimizing inflammation and tissue tension. For this layer, we recommend using 2.0 or 3.0 absorbable sutures, and again, performing varied interrupted sutures here. This layer can often come quite superficial near the dermal layer, so be careful to take your time and avoid any sort of dermal penetration, which can affect the integrity of the remaining layers. Finally, once you get to the superficial skin layer, it's recommended to utilize a running subcuticular suture with that reverse cutting needle like we previously described. Here we recommend using a 4.0 absorbable monofilament suture. And in contrast to the previous layers, this layer is going to be by far the weakest, but the use of those SH needles and the smaller sutures ensures that it's going to have the least amount of tissue trauma when it's healing. Finally, you can reinforce that last layer with glue, steri strips, staples, or further interrupted sutures. Next slide, please. So this slide really encompasses sort of the closure technique pearls that we really want you to think about as you go through this lecture. In terms of hemostasis, it's absolutely essential. Excess cautery is one of the culprits that can lead to tissue necrosis, so be careful to not use it excessively as you're closing these layers. Furthermore, the tissue handling, like we had mentioned before, is important, as crushing skin can lead to further necrosis and ischemia locally. Gentle handling is going to prevent that bruising and that maceration. Infection prevention actually begins before closure altogether. Copious amounts of saline can be used to irrigate, and adequate hemostasis can prevent those fluid collections from occurring. Antibiotic irrigation has no documented proven benefit written within the guidelines, but there's emerging evidence that uses of vancomycin powder, for example, can be useful, but it doesn't have any explicit definition or sort of recommendations in the existing guidelines at this current time. Next slide, please. So kind of taking all that and putting it together, we can look at this slide to kind of just review some practical pearls when it comes to neuromodulation closure. For device fixation under the fascia and the pocket itself, we recommend using a braided non-absorbable suture, something like Ethibond, which is commonly used. For fascial closures, it's recommended to use a braided absorbable suture, such as Vicryl. For these superficial layers, we can utilize a monofilament or a braided absorbable suture, such as Monocryl. And then for the dermal closures or superficial skin closures, it's recommended to use a monofilament absorbable suture. You can further supplement the superficial skin with glue, staples, or steri-strips. And in the scenario where a wound washout is performed, it's recommended to then close that area with a non-absorbable monofilament suture or staples. And that's because, in contrast to those braided sutures, a monofilament is going to minimize that risk of bacterial adhesion and fibroblast proliferation. Next slide, please. We'll now review some of the basic tenets when it comes to postoperative care for these permanent implants and IPG implants. In general, patient instructions are to keep the dressing dry, avoid soaking or submerging the area of the incision sites for an extended period until the area can be evaluated again so that you can assess it for adequate healing during an in-person follow-up. You want to optimize comorbidities to help improve your outcomes and give your patient the best chance. And this can include glycemic control and anticoagulation management. It's also recommended to plan for follow-ups around some sort of traditional plan time, so typically 10 to 14 days post-operatively, and to allow time for appropriate healing so that any staples or sutures can be removed at the appropriate time if they're present on the skin. Common infection warning signs are critical to keep account for during this process, such as fevers, chills, erythema at the site or nearby, drainage, any fluctuants, and any IPG pocket tenderness, for example. Next slide, please. When it comes to managing wound complications, it's first best to understand where are the common sites for infection after SCS implantation. This is most commonly in sites like the superficial wound infection, which can lead to seromas or local infection, the deep IPG pocket site, which can be infected, or the epidural space. Workup for a suspected infection traditionally includes lab work such as white count, ESR, CRP. If an epidural infection or hardware complication is suspected, imaging may be beneficial, such as MRI with contrast. CT imaging, by contrast, is often less sensitive overall. Per the NAC guidelines, if you do suspect infection, avoid any delay in empiric antibiotics, with a caution to try to tailor these as best as possible to any cultures that were collected. Next slide, please. In terms of managing deeper infections, traditionally this is going to be involving a more copious sort of invasive process. IV antibiotics and oral antibiotics in some combination would be recommended, as well as maybe consultation with microbiology or ID if available. Incision, drainage, and hardware removal for adequate source control is recommended for deeper infections that are suspected. At the time of explant, antibiotic or betadine irrigation can be recommended to be used. And in many cases, a JP drain can then be placed as well and kept in place with regular follow-up scheduled to see and measure the amount of drainage that's seen. Typically, JP drains can be removed when there's less than 20 cc's per day of discharge for 2 consecutive days, but this can be tailored per your practice and the specific case that's present. Next slide, please. In the event of wound dehiscence, it's important to understand that this typically happens around 5 to 8 days postoperatively. Risk factors for wound dehiscence include things like diabetes, connective tissue disease, cancer, immunosuppression, and then of course, any improper tissue tension that would have been a byproduct of closure or the initial incision. Although the evidence is limited, salvage can be attempted in some cases. However, in most cases, if infection or IPG compromise is likely, explantation as previously described tends to be recommended and is the advisable course. Next slide, please. And now we're going to move on to our Q&A section with the rest of our panelists.
I think you're muted, Dr. Lubin.
Okay, sorry about that. I want to commend all of our fellows for doing an excellent job. The chat box is open for the audience to send in any questions that they may have. But to initiate our discussion, I'd like to throw a question out to Dr. Suferri. We all know that diabetes impairs wound healing, but can you give us some specifics on what one should look for in terms of how to manage blood sugar control in this perioperative time frame?
So in the perioperative and postoperative period, glucose would be very important. I would be concerned about glucose levels above 200 and try working with the patient's primary care physician and or endocrinologist to make sure we keep it under 200.
All right, anyone else? Dan or you, sir, any questions?
Yeah, I'll ask a question to Dr. Delora. Dr. Singh talked very eloquently about all the things that can happen with our devices, and certainly you probably have seen that, hopefully at this point in your fellowship. What do you guys do? You're over at Rush, right? So what do you guys do at Rush for preoperative, intraoperative, and postoperative infection, or I guess infection prevention measures? What do y'all do?
Yeah, so it really starts preoperatively in the clinic. So like Dr. Suferri was mentioning, we're going to want to get diabetes control. In addition, we want these patients to stop smoking. Nutritional optimization is incredibly important as well. And then more perioperatively, we often give perioperative antibiotics. So we'll do NSAID, clindamycin, depending on what the patient has allergies to. And intraoperatively, we try to make our pockets fit the IPG site so that you don't have seroma development. We make sure that we get adequate hemostasis while not totally devitalizing the tissue, so we don't have any hematoma-related infections. And in addition to that, postoperatively, I know it's a little bit controversial, but sometimes we do antibiotics and regular monitoring. The antibiotics aren't really borne out by the NAT guidelines and some of the evidence, but it's something that you'll still see in many practices. So yeah, it really starts at pre-op and goes through post-op.
Yeah, thank you. I think it's just doing everything that you can and taking little steps and measures at every phase to make sure that you can do whatever you can to prevent the possibility of infection, because we know the infection rate for these devices is not negligible, right? So if you look at, depending on what you read in the guidelines or any papers, it's around 5%, right? So for every 100 patients that you implant, you're getting 5 infections. So I think these are really important things to think about. Thank you. Dr. Ibrahim?
For Dr. Singh, you hit really well on post-op complications and what may happen. How would you approach if your patient were to come for their first post-operative visit and they have signs of delayed wound healing? How would you approach it? What would be on your differential for that?
Yeah, I mean, so for that first post-op visit, you want to ask, as many questions as possible and really get a good look at all the sites, because your surgical site infection is going to be the most likely culprit if there are signs for that. In terms of delayed wound healing, you want to try to couple an assessment of that with, are there fevers, chills, redness, swelling, any discharge that wouldn't be appropriate for the site that you would see. Obviously, do a visual inspection of the area. Then you want to try to cover all the areas if there there's a possible infection brewing or if there's a deeper infection that is present but is not making itself as obvious yet. So you want to do a workup that involves a white count, looking at inflammatory markers like ESR, CRP, and if appropriate, if available, you want to try to collect blood cultures as soon as possible to obviously get ahead of any systemic symptoms that are present. For those patients, it's definitely recommended to then increase the amount of frequency that you're following up with them. So if you're seeing them, let's say 10 days or 14 days post-operatively, you then want to follow up with that patient much more frequently, maybe 5 to 7 days after that, to try to trend their symptoms and to look at the surgical site too. And then moving forward, it's really a conversation with the patient and also just a medical decision with their symptoms and how the site looks to make a decision on if you want to intervene if the site does look like there's any dehiscence or compromise.
Yeah, exactly. I think you hit a really good overall approach to it. And I think one of the key things that you mentioned is more frequent follow-ups just to ensure that their delayed wound healing doesn't progress and to ensure that, you know, they might not need to be taken back emergently for possible explant.
Let me throw out a question to all of the panelists here. We all know that a first generation cephalosporin is the first class of antibiotics that should be administered preoperatively before or immediately pre-incision for the types of procedures that we do. But what happens, what do you do as your alternative antibiotic if patients have a history of an allergic reaction to this initial group of antibiotics? What is your workflow to then choose a second choice or third level antibiotic? Anybody want to take that question?
So if a patient's allergic to a cephalosporin, second, I would probably consider clindamycin.
And then if they're allergic to clindamycin, do you have any other alternatives after that?
It would be based on their history. If they do have a history of MRSA or MSSA, obviously I would consider vancomycin, and possibly doxycycline.
Yes. And if patients still have an allergic reaction after that, you could use some of the other less commonly used medications, but you could use Bactrim or then alternatively erythromycin. But usually between Keflex, clindamycin, and then vancomycin, those are going to be your most common antibiotics that you're going to administer preoperatively for these types of patients. Here's a question from the audience. When do you allow patients to shower after implant if you're going to use Dermabond and Telfa type dressings? So again, anybody want to answer that, Adam or Sarang?
Yeah,
It's typically
so,
after. Oh, sorry.
go ahead.
Yeah, so it's to our understanding, it's typically after the first follow-up, after you initially see the patient. So at least a period of about 2 weeks when you can see the site after it's been uncovered by its initial dressing. And then if the site looks stable, then they should be allowed to shower after then without soaking the site.
Yes, we do the same thing as well. So yeah, agreed.
And then next question, Adam, what about patients who are taking anticoagulants preemptively or preoperatively? Is there any guidelines that one looks to on how to manage those appropriately? And when would you restart them, if at all, after your implant?
Yeah, so I always check because we have the ever updating ASRA guidelines as to when to stop these medications, especially with epidural access. So yeah, depending on if they're taking Lovenox, that's going to change my decision versus whether or not they're taking a DOAC. So I usually address the guidelines and follow whatever they say in terms of stopping and restarting.
Yeah, and when would you restart them?
Depending on the anticoagulant, it's usually 24 to 48 hours antiplatelet versus anticoagulant, or just really depending on what it is and what the guidelines say.
Yeah, 24 hours is usually sufficient. And then lastly, if somebody has unusually high blood sugars, let's say they're in the 220 or 250 range, but this patient has other constraints because they're holding their anticoagulant drug, how would you manage that patient perioperatively with the anesthesia care team? Is there something that one would do or could do there in your ambulatory surgery center or operating room environment to move forward with that patient?
Yeah, I mean, I would say probably giving them some insulin and bringing that glucose down.
Yeah, it's a very simple step. 3 units or 5 units IV, and then most importantly, you need to track that for those first 2-3 weeks afterwards to make sure it stays under that 200 level that we had mentioned previously. All right, I don't see any other questions here. I'd like to thank everybody for tuning in and listening to our presentation. The ASPN organization has some upcoming educational opportunities. These are just some of them. There's our annual meeting that's every year in Miami in July. There is also the pickleball event that's sponsored by the Young Innovators Committee at the ASPN meeting. So if you're really into pickleball, come join us in Miami. And then the last one is the ASPN meeting. The annual conference is in Amsterdam in October of this year. And so we'd like to thank everybody once again. I want to thank all of our panelists and my co-moderators for participating and helping out. And with that, I'd like to wish everybody a good night, and we'll see everyone soon again with our next webinar. Thank you.